Okay, so where to find the relationship between ICD-9 codes and the HCCs and whether they risk adjust or not. That is also available on the CMS site, and here is a reference to that location on the CMS site. And you'll see by drilling down into this area whether an ICD-9 code risk adjusts to an HCC, and there are also files in there that show HCC codes and which ICD-9 codes feed into and are counted in the HCC scoring. So as we move along to payments based on patient condition, I highly recommend you become familiar with these resources on the CMS site. And for your practice and for being able to introduce them into your documentation and your clinical throughput, not only in documentation, but in your electronic medical records and templates, etc. An ICD-9 documentation and coding resources that summarizes some tips that tracks along the disease organization of the ICD-9 manual will be posted to the Academy site. This provides some guideline application and documentation tips, and it also highlights some relationship to HCC risk adjustment. And again, due to the length of that material, I'm going to reference it today, and we will post that to the Academy site. There is an HCC score calculator I found, and this is a link to where that can be found. And it is by a health plan in California. And what it looks like, this is the front page of that HCC score calculator. You plug in this information about your patient, payment year, birth date, the demographic risk factors as we described, how they became eligible for Medicare, their original, and whether that was due to age or disability, etc. Which model, as Medicare has different models based on for Medicare Advantage, for PACE, ESRD, etc. And then to put the diagnostic codes in, and then it'll run through the process and provide a HCC score for you. Okay, so the role of documentation and coding. Again, as we discussed, ICD-9 codes paint the picture and drive risk scores. To manage care, to Medicare plans and other organizations, PACE organizations, and increasingly to shared savings practices. And it is also an underpinning of the Independence at Home shared savings calculation that is in place as well. All diagnosis must occur as a result of face-to-face encounter. And again, this includes services rendered by a physician, a nurse practitioner, or physician assistant. I want to provide you an approach to documentation that is referenced in literature, and this would enhance documentation and feed into the ICD-9 documentation process and approach to thinking about the diagnosis of your patient and documenting that service, and then also providing the documentation that would support your diagnostic coding and the HCC scoring that results from a medical review perspective. Okay, so the coding guidelines state that a condition must exist at the time of the encounter and affect patient care or management and be documented in order to be coded as a diagnosis. This approach, the acronym is MEE, to describe the 4 factors that help providers to establish the presence of a diagnosis during the encounter. And the acronym stands for monitoring, evaluating, assessing or addressing, and treatment. Quick review of that. Providers are required to document all conditions evaluated during each face-to-face visit and what should be included in progress notes, etc. Each diagnosis must be documented in the assessment and care plan and show that the monitoring, evaluating, assessing, or treating the condition is occurring. A simple list of diagnoses is not acceptable or valid, nor does a simple listing meet the definition of assessment and plan. And here's a further description of what meeting those requirements and following this approach would mean in terms of monitoring the signs, symptoms, disease regression, evaluating test results, medication effectiveness, response to treatment, assessing the ordering of tests, discussion, review of records and counseling, treating the medications, therapies, and other modalities. So continuing on, and here's an example of congestive heart failure, of what would suffice, major depression, an example of what would suffice as to the monitoring, hypertension, and not only should you show that evaluation and treatment at the time of the encounter should also feed into again your documentation, the other conditions that are addressed and treated, and there is information that I've reviewed that working on the diagnostic coding also supports your overall medical record documentation that feeds into your evaluation and management CPT code selection, and that there is a relationship between the levels of diagnostic coding, the HCC scoring, and the levels of CPT coding. And this was being studied by a large medical practice to see if there was such a relationship. Again, the last point here is that treatment is prima facie evidence of a diagnosis if you're treating. Therefore, the condition diagnosis should exist. You can use history if history of it affects the current treatment plan, and that it influences the ordering from that diagnosis. But just a sheer stating of history of means that the condition may no longer be in place. Okay, so medical record documentation. There's just some basic requirements or standards that hopefully you already have in place. Okay, basic ICD-9 guidelines. I'm not going to go over each of these specifically. They are here for your reference, and again will be posted to the site. Okay, so we have and these are the approaches are some helpful tips to ICD-9 guidelines, and again there is going to be a more exhaustive summary in addition to these posted to the site. Okay, those basic guidelines continue and continue. Last page, we do want to mention again coding of all conditions that affect required care, and the order of diagnostic coding is mentioned here, and the importance of coding specifically rather than generally, acute versus chronic, controlled versus uncontrolled, and not to report unconfirmed diagnosis. Okay, so practical tips on picking up and maintaining diagnosis are here. Again, won't review each of these in particular. They're here for your reference. And again, the fourth point though does show that how this supports the documentation and your history and your examination of patients, that diagnosis should also be backed up with the examinations of the systems or organs that are involved. This page can provide some common coding errors that have been identified, and these will be there for your reference. Conditions that need, chronic conditions or existing conditions that need to be submitted each year. And won't review these each year, in particular each item. Some of these do get risk adjusted, others do not get risk adjusted. However, these are conditions that do need to Some of them do, and they do need to be submitted each year. To the extent that the opportunity to list diagnostic codes is limited by the number, the spaces on a form, that was to increase under ICD 910. And we'll have to see whether that increases in the absence of ICD 10. But the way to approach this is to rotate as long as you're treating that condition and documenting that, to document that and then to rotate the diagnostic coding throughout the year. And again, to include these at least once per year. You want to code conditions even when medications or devices are covering up the symptoms. Here are some examples. Other missed conditions that affect, that do risk adjust mental health issues. And there's an example patient condition here. Even though the patient is stable on medications, and here's an example of the diagnostic codes for the patient's conditions. And the mental health, those codes would risk adjust. Also, what might be found often in your patient population, the protein calorie malnutrition, the diagnostic codes that range from 261 in the ICD-9 diagnostic coding manual to 263.9, that it's often a misdiagnosis, and some scenarios to consider in your patients, and some of the symptoms that may include. And again, to point out that this is a frequent condition or diagnosis of your patients, and a couple here to make sure that you're documenting as specifically as possible and that they do risk adjust. There is a group that's specific to the house calls population, or that's often identified. We will post that list, and I will note it to the listserv and also an electronic newsletter as it gets posted to the site. Okay, some, again, helpful tips in terms of nomenclature and what would support your documentation and the diagnostic coding and risk scoring. Okay, to wrap up, Academy resources by the various topics. We've discussed some of the areas that we're working on for Academy members and for the field in terms of the payment systems, payment codes, the standards, the new codes under development, the standards development, assistance with audits and compliance and documentation, such as today's webinar, and moving on to other topics that support your practice, and also to expansion of the IAH demonstration and to the field through lessons learned dissemination. Do look forward to seeing you all at the annual meeting in a few weeks. It's going to be just a great couple of days in Orlando, Florida. The evidence of the value of house calls will be discussed in programs such as ACOs, et cetera, and Medicare Advantage experience, such as we've gone over the overview of the importance of your services and documentation and results and services for those plans. Managed care, the VA services. Join us to celebrate the history and legacy of the Academy and house call field leaders, the name change and expanded membership, joining in the expert sessions and enhanced networking. Want to provide the opportunity to have you type in questions to us now into the space provided on your screens, and we'll try to address those real time, and to the extent that we cannot or they take some research, we will again collate those and post the questions and responses to the site. Again, there were resources mentioned. We covered a lot of material today from the underpinnings of risk adjustment approaches to paying practices and the evolution to population health models, the importance, where the risk adjustment systems came from, how Medicare adopted one, the technical underpinnings of the HCC system, the really critical importance of specific and accurate ICD-9 documentation that will also support your CPT documentation and code selection and submission and payment and practice revenue. Those resources, again, were cited, and we'll, again, post these resources and references to the Academy site, and mention those through the listserv and electronic newsletter and the e-news. And then also we'll post the specific guidelines that are helpful in ICD-9 coding and documentation. The services that have been, and diagnoses that have been found in the patient population that do risk adjust, and again, we'll let you know when those are posted. Okay. Please let us know again through the opportunity that's there on the screen, or through email to me here at the Academy at gary.swartz@aahcm.org of questions, resources. Again, we covered a lot of material this afternoon, but again, we'll back that up with resources on the site. We'll discuss these topics at the annual meeting, future Frontiers articles. Please let us know what you're doing, how this type of information assists, what other information you need to support your practice, or questions you may have about opportunities that may be in the marketplace, or things that we should need to know here in order to advocate on your behalf as effectively as possible. And again, do look forward to seeing each and everyone at the annual meeting in a couple of weeks. Again, the Planning Committee has produced a what should be a very fulfilling, both professionally and interpersonally, couple of days of meeting and networking in a great venue. Thank you for joining us this afternoon. Again, look forward to your questions and comments, and thanks for joining this afternoon, and talk to you again soon.